Welcome to those who are joining us. Please let's give like 5 more minutes for other participants to join. Thank you very much for your patience. Thank you very much for joining. We'd like to request that we give like 2 more minutes for other participants to join and we start at the top of the hour. Thank you. Good morning, good afternoon, good evening, ladies and gentlemen, wherever you're connecting from. Thank you very much for your patience. And we would like to welcome you to this special webinar event, which is on the oxygen resolution. So just for some housekeeping rules, please kindly mute your microphone when you're not speaking. There is a chat box where you can leave your questions, and we'll, in case of need, you may be unmuted to contribute as we move along the program of today. So the COVID-19 pandemic has exacerbated the need for oxygen as a key drug in the management of respiratory diseases. And this need requires that oxygen should be sustainably produced, procured, distributed to ensure that it's made accessible to the people who really need this. So with this highlighted importance, Uganda, in collaboration with other countries, drafted a resolution for the World Health Assembly entitled Increasing Access to Medical Oxygen. So the objective of this webinar is to increase awareness and rally support from African Union member states when this resolution would be discussed during the 76th World Health Assembly, which is going to happen in a few days. So the second objective is for us to also keep you aware about where do the efforts that were developed for access to oxygen during the COVID-19 pandemic, where do we want to take it from here? And this would be highlighted by us telling you about the launching of the Global Oxygen Alliance, which is a working group to ensure that the momentum to access to medical oxygen remains. Without much ado, we are going to start our webinar with a slight modification of our program of today. Dr. Radhika Dudin, who is supposed to give an opening remark for Africa CDC, will be joining us in a few minutes. So I'm going to give the floor now to Dr. Charles Olaro from the Ugandan Ministry of Health to tell us a little bit about why the oxygen resolution was submitted. Dr. Olaro, over to you. Thank you very much. Dr. Olaro, can you hear me? Dr. Olaro, if you're speaking, you're muted. Blade, can you hear Dr. Olaro?
I cannot, Dr. Temfax. So I think you may want to go to Ms. Adriana Barumam from WHO, and we'll see if we can connect Dr. Olaro.
Okay. Adriana, over to you. Thank you.
Yes, thank you very much. Thank you for allowing me to be in this. Thank you to Every Breath Counts and Africa CDC for inviting WHO to this special webinar event to support the increased access to medical oxygen. Needless to say, exactly what you were just commenting, the last 3 years that have been really impactful in everybody's life, and the lack of oxygen was highlighted. Oxygen, as we all know, oxygen is indispensable for life. Medical oxygen has been originally listed in the WHO Essential Medicines list as a medical gas. And it was not until 2021 that it was listed in the Essential Medicines book and publications for hypoxemia. But let me tell you that this process to include it in the Essential Medicines list did not start during COVID. It started before, because we had already noted that oxygen was really needed. Oxygen is absolutely indispensable for healthcare provisions in the treatment for acute and chronic diseases, during surgery, critical care, emergencies, trauma, and respiratory diseases. The lack of medical oxygen in many healthcare facilities, especially in low and middle income countries, has been noted for decades. And we do have publications even in WHO, but due to the complexity of the infrastructure, the supply, and almost no investment had been done. But it was really during COVID-19, as you were just commenting, that the whole world really realized the absolute need to have available medical oxygen of good quality as the utmost important treatment for patients. This triggered, number one, acknowledgement, number two, recognition, and number third, actions. WHO developed in record time training material, guidelines, technical specifications for the medical devices required to deliver, control, produce, or monitor oxygen. The International Pharmacopoeia was modified not only to include the 99% oxygen from liquid oxygen production, but also the one produced by PSA plants to ensure access to oxygen of good quality was increased. The ACT-A health systems, and then since 2021, the ACT-A therapeutics highlighted the urgency of medical oxygen provision in all member states. Therefore, multiple stakeholders have participated to increase access to oxygen, but much remains to be done. Funding, policies, access to infrastructure, training, but one of those actions to call the attention to the whole world is a WHO resolution. Now, let me tell you what is a WHO resolution, the process and the expected outcome. First of all, the World Health Assembly. It is a decision-making body. It is attended by all delegations from the 194 member states, and it focused on specific agenda items that were prepared by the Executive Board. And one of the main functions of the World Health Assembly are to determine the policies of the organization. In this case, the WHO 76 that will take place 21 to 31st of May will consider a topic that was discussed in the Executive Board 152 in February on access to medical oxygen. If WHO approves the document that was proposed by the Executive Board, then it will become a WHO 76 resolution with a consecutive number with the other topics approved by the member states. These resolutions are normally approved by consensus, although maybe that are really conflicting might have some reserved paragraphs. And we don't foresee that for the oxygen resolution. It is also, just in brackets, to note that specifically this year, the WHO 76 also celebrates the 75th anniversary of WHO. So this is a very important assembly, and we really want that they all approve the oxygen resolution. Let me tell you now about the process that led us here. The government of Uganda, as you all know, proposed the EB conference paper to be included under the health systems to primary healthcare as a resilient foundation for universal health coverage. And that, under that includes this subtopic. There's other subtopics like the emergency care. There are other subtopics like diagnostics, but oxygen is one of them. Yeah. So 2 informal consultations with member states took place 18th and 20th of January. And we really want, as WHO, to thank Marina Momo from the Uganda mission in Geneva for her excellent chairing of the member states discussion. In general, there was consensus. Nevertheless, there were some member states that required some adaptation or some changes, but at the end, we reached consensus. And we were very happy that the EB draft document was submitted to the EB. And then during the EB, the proposed resolution had wide support from member states, as you all know, from African countries, the European Union, USA, and many others that lead and our colleagues put in the invitation for this program. Very important was to know that there were not any member state that had any reserved text. There were no controversies. All of them recognized the need to increase access to medical oxygen everywhere and to everyone. Sorry, I just get emotional because this was really important. As you know, the draft resolution includes 11 preliminary paragraphs. That gives us like the background, what has happened before. So it describes always like things that were as a background information that has to be taken care by member states when they read it. Then they have 20 operating paragraphs for member states. Those are non-binding, not legally binding, but that's a recommendation that WHO does for member states to take action. So they're listed one by one as you all have read them. I will not go through them. And then it has 11 operating paragraphs for the Director General of WHO. Those are binding to WHO. So we as WHO staff need to be sure that all those 11 paragraphs are activities that we make, tasks that we have to ensure that they are made. This will be discussed, all this will be discussed normally in agenda item 13.1 that normally will take place Monday or Tuesday of the World Health Assembly. And please note that the agenda changes as per the time dedicated to each topic. So the time is not exact. It really depends on the discussion by member states. So this resolution, as you all have seen, calls for continued efforts to increase access to oxygen, including funding and operating oxygen systems, training for healthcare workforce, and ensuring that really oxygen is available everywhere what it would need it and for everyone. Medical oxygen generation, the distribution, the delivery requires a whole infrastructure that you all know that is very complex. And it needs to be to ensure that oxygen is of good quality. It has to be delivered safely, appropriately, using the required medical devices. The impact. What do we expect of the resolution? Well, we expect that the resolution will raise attention, awareness, advocacy of the importance of oxygen. We all knew it, but this is a very formal way to do it. We would like to have policies to ensure access, the availability and training of the health workforce, and the increase of oxygen-related technologies, and also innovations, future developments to ensure everybody has access. We also expect to raise awareness on the essential importance of oxygen, not only to ministries of health in member states, but to all the healthcare workforce, to the NGOs, to the academia in universities, medical technology industry, and from investors. WHO, as you all know, is not starting from zero. We have been doing assisting work on oxygen for 3 decades along the 3 levels of the organizations, but never before in the way we did it the last 3 years. After lagging for decades, much investment has been done in 2021 and 22 for new infrastructure for medical oxygen. Now, training, operation of the whole oxygen system from production to distribution, regulation, maintenance to safe use have been enforced. And this resolution, along with many other measures taken during COVID, would increase political and technical attention to the availability of oxygen, especially for low and middle income countries. The importance of multidisciplinary, harmonized collaborations between clinicians, respiratory therapists, pharmacists, biomedical and mechanical engineers, along with all the other stakeholders, is indispensable to ensure oxygen is delivered to all patients that need it everywhere. You would agree with me that oxygen is indispensable for the well-being. WHO welcomes the Global Alliance for Oxygen to continue the work, great work initiated by the Oxygen Task Force. Also welcomes very much the new Lancet Commission for Oxygen Security launched in 2022 and many countries and NGOs initiatives. This resolution will give WHO a specific mandate. As a WHO staff myself, we have a huge responsibility, but only together with all of you, we can ensure that access to be improved for everyone, everywhere. Thank you very much.
Thank you very much, Ms. Adriana, for your remarks. I think they were clear enough. I'm just wondering whether Dr. Olaro has succeeded to connect. Dr. Olaro, are you with us?
We are still trying, Dr. Temfak, to connect with Dr. Olaro. I suggest you move to the next session while we wait. Okay,
so while we wait for Dr. Olaro and Dr. Tajudeen to connect, I'm going to give the floor now to Ms. Phoebe Kagame of the Oxygen Alliance, who is going to moderate the next section of our webinar, and then we'll come back to the previous speakers. Over to you, Phoebe. Thank you.
Thank you so much, Dr. Temfak and Adriana, for taking us through the process that resulted in a draft resolution, and most of all, for your passion in access to oxygen everywhere and for everyone. Now, I'd like to take us back to when we were in the eye of the pandemic, and there was a popular question that went around, and that is, who led the strategic innovation of your organizational field? The choices given were board, CEO, and COVID. What do you think majority of the respondents answered? Yes, COVID. Good day, everyone, and thank you for joining us in this session on Oxygen Success Stories. My name is Phoebe Kagame, the Director of the Oxygen Alliance, and I will be moderating the next part of our meeting. The Oxygen Alliance is a coalition dedicated to creating a resilient and sustainable ecosystem for maintenance and repair services of medical devices in LMICs. As we've heard Adriana mention, that there are quite a number of equipment that have actually been donated and even given, especially in the last 3 years. We work through 5 pillars that target all key actors who impact a country's ability to transition to a more resilient health ecosystem. That is government, biomedical engineers, donor and funding agencies, manufacturers, and academic institutions. Our call to action is for all stakeholders to invest in the necessary resources and continue to prioritize maintenance and repair. We welcome all participants and viewers today to consider joining the Oxygen Alliance. We have some exciting upcoming work, including some new innovative products from our members. Our website is www.oxygenalliance.org.
Did we lose Phoebe?
Sorry. Can you hear me now?
Yes, we can hear you.
Good, sorry about that. Now, it shouldn't take another pandemic for us to acknowledge that the approach and support to oxygen activities have been fragmented. The need for resilient and sustainable systems is critical now more than ever, and we should continuously advocate for investment and building of the medical oxygen ecosystem. LMICs faced a huge lack of oxygen systems and supplies even before the onset of the COVID-19 pandemic. But surging needs due to the pandemic gave these shortages prominence. Taking on a collaborative approach and support to oxygen activities, we have convened panelists who represent different critical stakeholders in the access to medical oxygen and relatable technologies, right from government level through to sourcing, distribution, monitoring, and last but not least, repair and maintenance. Our panel of experts will share their experiences and success stories on topics ranging from the design and implementation of a national oxygen roadmap, as we'll hear from Ethiopia, the vital role of pulse oximetry in the rational use of medical oxygen from Mali, how to dramatically increase local production of medical oxygen from Rwanda, and how to build oxygen capacity within health ministries. And with that, ladies and gentlemen, let us hear from our first panelist, Dr. Lulu, who will guide us through and share with us inspiration because Ethiopia is one of the only 2 African countries, with the other being Nigeria, that prior to COVID-19 had an oxygen roadmap. Dr. Lulu would like to find what impact having an oxygen roadmap had on Ethiopia's healthcare system, particularly in terms of improving access to medical oxygen, and how you have ensured sustainability of the roadmap beyond initial implementation. Welcome, Dr. Lulu. Dr. Lulu, can you hear me? If we can't get Dr. Lulu, then I think I'll move to another speaker in our session, and that is Dr. Sidibe. Have you connected to the translator, Liz?
Translator is still trying to connect from Ethiopia. I recommend we move to Miss Francine Umutezi and come back to Dr. Sidibe.
Sure thing.
Bonjour, Dr. Sidibe, connecté en ligne. Dr. Sidibe en ligne. Bonjour.
Sorry, the interpreter is on, but not assigned as an interpreter. For that reason, you cannot receive the service on my part because I'm not accessing the interpretation platform. Sorry for that. Thank you.
Apologies for that. I will proceed with Ms. Francine. Ms. Francine, Rwanda's COVID-19 response strategically included an oxygen production roadmap that resulted in a significant increase in its production volume. According to the World Bank, Rwanda's production capacity increased by more than 600% from 2020 to 2022, with the ability to produce 2,500 oxygen cylinders of 50 liters each day. This success story serves as an example of how a country can turn a crisis into an opportunity to strengthen and improve its health systems. With that, Ms. Francine, would you please share with us how you overcame the biggest challenge, often cited as these infrastructural challenges, how you have worked over this in terms of implementing the framework to scale local oxygen production?
Thank you so much, Phoebe. Thank you for the opportunity. So in Rwanda, I would say that we were very lucky because we had a system that already existed and helped us to quickly respond and try to overcome the pandemic, which is why I wanted to show you first our health sector organization. Quickly, next slide. So as you can see, we have our health sector organized as a pyramid, starting from the lowest of the lowest level, administrative level, which is a village. We have healthcare workers at that level who help house by house respond or with information on healthcare. We have health posts at the cell level. As you can see, we are still having some gaps, but we are getting there. We have 2,000 and around 2,000 cells and 1,000 health posts. When someone needs more care, they go to the health centers. And from the health center, they go to the district hospitals, then provincial hospitals and teaching hospitals. But the most important thing is at the lowest level is where 90% of the disease burden is treated, which is where we are hoping and we are trying to develop a strategy to avail oxygen properly in the next coming year. Next. So these hospitals are organized, next slide, please, under the Ministry of Health, which has different institutions, Rwanda Biomedical Centers, Rwanda FDA, Rwanda Medical Supply, who help in the implementation of the health policies and programs. I will elaborate a bit about Rwanda Biomedical Center because that's where our division work from. Next slide. We have a department called Biomedical Services, which has blood transfusion, national reference laboratory, and the medical technology division. So at the beginning of the pandemic, our division was tasked as usual to ensure accessibility to healthcare and availability of infrastructure. And the first thing we did was to assess what do we need for COVID COVID-19 case management, and oxygen was one of the key medical essential drug to be dispensed to patients and to help. So what we did on next slide is to initiate immediately in the first month of the pandemic. We had our first case in Rwanda in March, on March 16th, if I'm not mistaken. And then we started immediately the process to avail oxygen. We procured 26 oxygen plants dispatched in different hospitals strategically to be able to distribute across the country. We had 8 old oxygen plants rehabilitated, which helped us to upscale our production threefold, like you mentioned. But then we realized that the oxygen plants are producing oxygen, but how do we get it safely to the patients? And we started upgrading the infrastructure as well, which is very important because having cylinders on each patient, not only it's a hazard, but also it's uncomfortable. You can't have staff manning a cylinder on each patient, especially if the patients are receiving, getting high consumption of oxygen. So we were able to upgrade the infrastructure, oxygen piping in all our hospitals. Presently, we are following up on installed systems to correct some snags, but all of them have been already completed. Several oxygen delivery equipment, including CPAP machines, oxygen concentrators in different hospitals where they do not have, in health centers, for example, or ambulances where they need these accessories. We procured different accessories such as oxygen masks and others. As of now, we have a new field hospital of 91 bed capacity, procured and installed just for such a pandemic or emergency cases. We also have upgraded one health center to help treat and house patients who need highly and critical respiratory care. So these piping were installed in isolation rooms in different hospitals, ICU, operating theaters, maternity and neonatology, accident and emergency, pediatrics, surgery, internal medicine. This to highlight that it wasn't only to manage COVID, which was the most important one at the time, but we thought also about strengthening the system so that we can be able to respond to such a crisis or to treat patients properly for other diseases. Capacity building was also conducted, but there is still much to be done. Next slide. We are taking an approach to support different building blocks and be able to manage the oxygen ecosystem, touching all the areas, all the aspects, such as availing equipment and infrastructure, like some of it I mentioned. But if you have those, you will need the workforce to manage and properly dispense the oxygen. So this also is an area which is being improved. We also needed to upscale or to help improve supply chain systems, be able to avail consumables and spare parts on need. Data systems is being developed to be able to monitor not only where oxygen is available, where oxygen can be distributed from, depending on availability and location, but we will also help upgrade our medical equipment management and maintenance system to be able to manage the equipment procured along its lifetime. We also want to develop many systems to be able to properly monitor oxygen distribution. We also invested and supported integration and decentralization in different areas. I mentioned it. Proper maintenance in clinical engineering departments are being enforced to given more staff, given more capabilities to be able to manage properly the plants and also the systems installed. And of course, that requires some financial capability, which are being raised and through partners, different partners across the world. So we also think it's very important to think about policies to be able to have guidelines, SOPs, so that these systems are well managed, safely managed to ensure safety of patients, but also of the staff. So this is all from me. I just wanted to share what we have been doing and what we are putting our efforts into to be able to share our experience and hear from others as well. Thank you so much.
Thank you so much for that, Francine. I mean, I think you have talked about the key steps and or essential components to increasing local production. Most of all, also have looked at how sustainability can be done from the local level. I think it's very important that we all agree that even as we look at procurement and upgrading, it goes hand in hand with maintenance and repair of the systems that we actually have in action. So it's great to see that I am also very happy as a stakeholder in the repair and maintenance space, that it is important for stakeholders and all actors present to invest in the necessary resources to continue prioritizing maintenance and repair. And ultimately, for all these different areas that we are looking at, that systemization through policies and guidelines is the way to go. Thank you so much for that, Francine. I'd like to check. I'd like to see whether we finally have managed to get Dr. Lulu in. If not, I'll proceed with Dr. Shitak. Do we have Dr. Lulu on the call? I think we'll move to the next session, and that is, I will now invite Dr. Shitak to share with us how building oxygen capacity within health ministries is important. Dr. Moeti, the World Health Organization's Regional Director for Africa, said during a WHO press conference back in 2021 that African countries were only producing a third of the medical oxygen needed during the third wave of the COVID-19 pandemic. With that, Dr. Shitak, what would you say is the importance of data to inform demand and supply strategies in sustaining oxygen capacity within health ministries?
Good morning, everyone. Thank you for your question. The importance of data cannot be overemphasized. In whatever field of endeavor, you need data for you to be able to plan properly. Without data, you won't be able to plan properly in any endeavor of human existence. And I can tell you that oxygen is not left out. It is very important for us to be able to establish what are the gaps, like the last speaker has just mentioned. You need to know what are the gaps, what are the challenges, and what are the things that you have done so well, and can you even be able to multiply them in other facets. These are the importance of the data for us to be able to put the whole oxygen ecosystem in place. And of course, when we put our data and we now look at the planning, we now realize that, okay, government alone may not be able to do all this. So we had to go on to have a coordinated resource mobilization from private sectors, implementing partners, and other United Nations bodies for us to be able to meet the oxygen production, distribution, and even the supply mapping in the whole country. With this, we have been able to use data to be able to look at the gaps and to be able to make up our challenges in every facet, from installing oxygen plants, from working with ASUs to be able to have liquid oxygen supply, and for us to be able to also have diagnostic equipment procured, and of course, distribution of the cylinders, and also piping of the systems to be able to deliver oxygen to patients requiring them adequately. Thank you.
It's great that you've mentioned the fact that having data supports in planning of all these different facets. So how can we ensure that health ministries have the necessary resources to implement all these things that they are working towards from the data that they have achieved?
Thank you. Like I earlier said, ministries alone or governments alone for a low, medium income countries like us, like Nigeria, for our setting, I doubt much if government alone will be able to do everything. But having data is important for us to be able to establish the gaps, then look at the resources required, then map out what we have and what we don't have, so that we will be able to work hand in hand with implementing partners, with the private sector, to improve the infrastructure using the available resources, and then, of course, to be able to build the capacity of healthcare workers and to be able to procure tools, and then continuously we will be able to show up the improvement in our data system, and we'll continue to invest. But while investing, it is important to have accountability, because where you put in a naira and you are not able to produce that 1 naira, even though being a social services, but patients don't access oxygen free. They access it whether by out of pocket or healthcare insurance, whichever one, there is a payment system. And so we have to ensure accountability for whatever infrastructure, for whatever cylinders, for whatever volume of oxygen we are producing, so that any other patient requiring it will be able to get it at the right time. So this is what we're using data to be able to mobilize resources and to implement our programs actively. And most of the programs stem from infrastructure to the distribution, to the training, to be able to mobilize, to be able to diagnose hypoxemia accurately, and to be able to know that, oh, this patient has properly received adequate oxygen. And that is why we will continue to invest in data, and we will continue to utilize that data to plan going forward. But finally, I can let you know that I don't know about other countries, but in Nigeria, I don't think the Federal Ministry of Health alone will be able to procure all the necessary oxygen required. But it is usually good to put your first foot forward so that you can get assistance from other countries or other donating agencies or even private sectors. Thank you.
That is a very important point that you've raised, Dr. Sheta, partnership and collaboration working together. Yeah. So I think with that, I also like that you brought towards the end in terms of accountability and costs. And I know the one thing that comes up is the cost of medical oxygen. How could we work, or rather, how can we work to ensure that the cost of medical oxygen remains affordable to patients, as you lead us to the next session?
Yeah. From what I have said so far, and of course, the cooperation with development partners, implementing partners, donor agencies, private sectors. Of course, if we're able to show some reasonable accountability and be able to keep the oxygen production plants going, we will be able to, of course, reduce the price of oxygen. Because once production goes up and consumption also goes up, of course, the little that people are able to pay will be able to keep the oxygen infrastructure running. And then with that, when you have the availability of the oxygen, of course, the cost will come down. I'm not an economist, but I do know that once it is very much available, of course, the cost will come down. But it is important for us to, with that partnership, we should be able to ensure that the equipment maintenance, the plant maintenance, all these things are done with minimum training of the biomedical engineers. And with that, we will be able to maintain this equipment functioning, and the oxygen is producing at maximum capacity, and patients are able to support. You can subsidize it for the less privileged patient using the health insurance system that is already in place in Nigeria, even though there's still a huge number of Nigerians who are not on this health insurance. They depend on out-of-pocket expenses, but the country is working towards achieving all this so that we'll get more people on health insurance, so that we'll be able to subsidize it for everybody, so that it can become affordable to all Nigerians, because it is very essential and it is required, not just because of COVID-19. In fact, Nigeria started working on oxygen because of childhood pneumonias, long before COVID came in. But when COVID came in, of course, we were overwhelmed, but the federal government tried its bit by supplying quite a number of oxygen plants. And with that, we were able to get a lot of support from other partners and other countries and private sectors for us to be able to build the system that we have now, with almost about 60-something additional plants already functioning, apart from the ones that were repaired for us by Global Fund. So we have quite a number of PSA plants functioning, and we have quite a number of cryogenic tanks coming up, and we are speaking with private sectors that have ASU, so that we will be able to get cryogenic oxygen supply to these tanks. And with that, when we have all these supplies adequate, of course, we will be able to drop the price as much as possible, because what we will require is just maintaining them going forward. Thank you.
Great. I think we can now proceed to the next session of your presentation.
Sorry, I didn't hear that.
We can proceed to the next session of the presentation.
Okay. All right. So next slide then. Yeah, like I just mentioned in some of the answers I put.
Please, Maya, can you mute your microphone? Thank you.
I'm having a lot of echoes. I don't know where it's coming from.
You can proceed, Dr.
Okay, thank you. You know, like I mentioned in some of my response to your questions, there are, of course, a couple of barriers that may need to be addressed to ensure that the supply of medical oxygen gets to every Nigeria in the country. We start with production, delivery, and of course, administration to the patient. So in Nigeria, what we did was establishing the oxygen decks. which, like I mentioned earlier, we started earlier because of the prevalence of childhood pneumonia. So we started working since 2016 with a child. Then we have gone on to be working with a lot of other partners. Now we work with FHI 360, UNICEF, WHO, Save the Children, and several other partners. You said we're all working with them on different forums and different oxygen coordination. We have a national coordination called United for Oxygen, of course, which every implementing partner in whatever form of oxygen is available on that. So with the creation of the oxygen decks at the Federal Ministry of Health, we thought it wise that, of course, for us to have adequate data, for us to map everybody so that no one is left out, we created the similar oxygen decks with coordination forums in each of the 36 states of the country, plus the FCT. And with this, we believe that each of the state coordinating forum would be able to assess the gaps required in terms of production, distribution, capacity to even diagnose hypoxemia and to be able to deliver oxygen to patients adequately. We took in a lot of things. So with the United for Oxygen and with the formation of the oxygen decks and the oxygen forum in all the states, which I think the last one is being done at about now in Kwara State, so that we have people collecting data, looking at all the gaps that there is and looking at all the other things we're doing so well, giving us feedback so that we will be able to move to the next stage. Our target is that at the end of the day, every Nigerian should be able to access oxygen within a short distance of about 50 kilometers away from his or her hospitals. As of now, many of the hospitals in the country might have to travel long distances to be able to access oxygen. But once we have the 63 plants delivered in the country, virtually all what we call senatorial districts in the country will have an oxygen plant. The senatorial districts are 3 within each state of the country. Once we're able to have that, the oxygen production plant would have been nearer to the facilities, which will form like a hub for them to be able to take their oxygens from there and deliver to the patients at their own facility. So with that, we have been able to have a good coordination. We have been able to map the country. And with that too, in our newly launched strategic program, strategic document, we're able to put a better roadmap compared to the initial one that was developed in 2017. And I think with this, in no long period, we will be able to conquer all the barriers that we presently are experiencing in this country. Next slide, please. I have touched on most of the things I just said now, because with that coordination at the national level and with the establishment of the oxygen decks at the sub-national levels, our coordination has greatly improved. We are actually looking at a situation whereby with time, we will be able to even extend the coordination down to the local governments, which are where most of our people reside. By the time we're able to do that, I can tell you that our coordination will be so good that we'll be able to actually optimize all the investments that we're doing at national and sub-national levels, because we'll be able to map our difficulties, map our requirements, and to be able to meet them gradually depending on the budgetary provision, both at the national and the sub-national level. With the coordination forum also, we are looking at the capacity building of all the relevant stakeholders, especially the clinical workers and the biomedical engineers. Because for now, countries in Africa don't produce oxygen plants. And since we rely on other countries, we need to learn, the biomedical engineers need to be able to know how to maintain, being in a PSS plant or being in a cryogenic oxygen tank. We will need to be able to do simple maintenance on the production, and then of course on the delivery equipment, should be able to do some maintenance to be able to keep these facilities going. We have a lot of oxygen concentrators too, but as long as you don't maintain them, you don't service them, you don't change filters, they become useless after a while. So it is very, very clear to us that we need to build the capacity of biomedical engineers, which for now, I would say the country is thankful to FHI 360 and CHI, because they are vigorously building the capacity of these biomedical engineers for us. And I think that is very important for us going forward, because if we are not able to maintain these equipment, they will soon break down, and then we will back to square one. Like some time back, we were in South Africa with FHI 360. A certain trauma surgeon said something that it touched my heart. It was a little bit annoying, but it was a fact that he stated, that most of these oxygen PSA plants are being donated to some African countries. Some of them might remain in the crates for the next 20 years. And I found that challenging, because they might remain in the crates for the next 20 years, probably due to lack of capacity of our biomedical engineers to install this. Because if somebody donates an equipment to you and you cannot install it, actually it's useless, because you should be able to install it and utilize it for the good of your citizens. Like I said, the data system, of course, the oxygen decks are collecting for us. It helps us keep the inventory, and it helps us plan procurement, and it helps us also look at what are the oxygen related indicators so that we can make proper decision. But without trained manpower, without well-trained people to be able to capture this data for us, it will be a problem. Right now, the oxygen decks and the oxygen coordination forum in the different states are being equipped by these same partners I mentioned earlier. Many of them are supporting us to equip these oxygen decks and to also train them on how to use those equipment and how to apply themselves to be able to capture all the necessary indicators that will help the country in decision making. Yes, you make a decision. You have an oxygen plant or you have an oxygen tank. How do you account for every liter of oxygen? How do you account for the maintenance? How do you account for electricity that you are using to generate this oxygen? These are all the other frameworks we are really, really working on them to ensure that these investments, they don't go down the drain. We're setting up teams. We're training and retraining people to be able to at least be able to say, I am producing so quantity of oxygen from my plant. And what I get from the ward is that this ward consumes this quantity, that ward consumes that quantity. And I can say that all the oxygen that is being produced from my plant is being consumed in the hospital and is being accounted for. I know where it is being delivered. But when you don't know, it is a big, big problem. And you may not be able to run the system, and you may not be able to maintain the production plan or even the equipment that is used in diagnostics and treatment. You need to be able to work on this, able to maintain them, able to service them, so that at least you can account or you can know that this is being useful and not being kept in the store or not being maintained in the crate for 20 years like someone predicted. Financing, of course, is a bit difficult too. Like I said, most of the countries in Africa are a little bit
I'm sorry,
poor.
Dr. Shetak. I'm sorry. Maybe I could request to please wrap up in the.
Sorry? Is my time gone?
Yes, you have 2 minutes. You can wrap it up.
Oh, fine. Let me round up. Yeah. So with the coming of with the COVID-19 outbreak, of course, it is a blessing in disguise because most countries have come to the support of their health system with oxygen production and maintenance of the equipment. And these have also helped us in mobilizing resources from private sectors and other donor countries and partners. Of course, supply and decision making, those are the things that as long as we are able to get feedback from our oxygen decks in the 36 states, we will be able to keep the supply structures and be able to look at our supply models to be able to modify them going forward. Next slide, please. With this, that's the end of my presentation, and that is what we are able to do with the creation of oxygen decks at the national and at the state level. Thank you, ladies and gentlemen.
Thank you for that, Dr. Shadrack. I'll hand it over to Dr. Temfak to take us to the next session.
Thank you very much, Phoebe, for that session. I think before we move to the next, I would like to catch up part of the agenda to give the floor to Dr. Rajita Judin of Africa CDC to make some remarks and tell us about Africa's new public health order and access to medical oxygen. Dr. Raji, you have the floor.
Hello, can you hear me?
Yes, we can hear you very well.
And can you see me as well?
Yes, we can see you.
All right. No, thank you. Thank you so much. Elvis, for a very important webinar like this. Let me also thank other partners who have joined Africa CDC to really organize this important webinar, especially our colleagues at Every Breath Count. So I bring you greetings from the Director General of Africa CDC, Dr. Jean Kasai, whom I'm currently with here in Cape Town on another important meeting, which is why I'm joining this webinar very late. So let me start by congratulating the countries who have stood firmly behind this resolution, this increasing access to oxygen resolution, starting with Uganda under the leadership of President Yoweri Museveni. Colleagues, ladies and gentlemen, according to Robert and Zach, two of our colleagues, Robert in Unit 8 and Zach with Clayton Health Access Initiative, in one of their papers, he said that no one, no matter where they live, should die from lack of oxygen, a condition we can diagnose easily, a condition we can treat affordably, and a condition we can prevent globally. This is true and nothing but the truth. So no one should die unnecessarily from lack of oxygen. Let me also go a step further to say that it took us a pandemic, the whole world a pandemic, or it took most especially Africans a pandemic to remind a continent of 55 countries and 1.3 billion people that we have lack of equitable and affordable access to oxygen. In fact, it's only 1/3, of our population that have access to oxygen. So 2/3 has no access to medical grade oxygen. This is no doubt unacceptable, and there is no way we can guarantee our security this way. We've seen with the COVID-19 pandemic, the rise of global protectionism and nationalism, and this has clearly highlighted the need for us to begin to address our problem with our own solution. That's African problems demand African solution. And of course, this is one of the reasons why Africa CDC has launched what we call the new public health order, which I will unpack shortly. The COVID-19 has also taught us that over-reliance on external sources and procurement without a very robust global supply chain management system actually put us at a very, in a very vulnerable situation as far as common illnesses, as far as outbreaks are concerned. We've seen how many of our countries face a lot of challenge during the COVID-19 pandemic. We saw the way people died, during the COVID-19 pandemic just because of lack of oxygen. Colleagues, I believe you will agree with me that there is no universal healthcare without equitable access to medical grade oxygen. We know that oxygen is on an essential medical list, but yet 2/3 of our population do not have access to what we describe as being essential. So really, one wonder, how do we attain our health security this way? But we are not just folding our hands. The African Union have called for this new public health order that is underpinned by 5 critical pillars, I beg your pardon. Number 1 is to strengthen our public health institutions. Number 2 is to strengthen health workforce capacity. Number 3 is to strengthen local manufacturing capacity to what I describe as health security commodities. Vaccines, diagnostics, therapeutics, life-saving equipment like oxygen, medical consumables like personal protective equipment. We need to begin to manufacture all this if we are to guarantee our health security sovereignty as African population of 1.3 billion people. Number 4 is domestic resource mobilization. And number 5 is respected and action-oriented partnership. Colleagues, you will agree with me that if we're able to achieve this new public health order, it will take us a step closer to being oxygen sufficient on the continent of Africa. Colleagues, investment in local medical grade oxygen manufacturing in Africa will result in a lot of benefits. It will help us to guarantee our security sovereignty. It will bring tech transfer to our continent. It will build necessary talent, and much more importantly as well, it will also contribute to economic growth on the continent. After all, we cannot talk of health, or we cannot talk of development without health. This oxygen resolution, colleagues, recognizes the vital importance of medical oxygen supplies, particularly in terms of maternal, newborn, and child mortality. And of course, that resolution has clearly outlined what we need to do at the national level to be oxygen sufficient and reduce this unnecessary deaths. Critically, that resolution has called for the need for national medical oxygen plan. And as Africa CDC, we stand ready to support each and every member state, working with the different partners, including Every Breath Can, Clean Health Access Initiative, Save the Children, UNICEF, and so on and so forth, to make sure that we support our member state to have in place a national medical oxygen plan that is costed and allow the necessary mobilization of investment, to drive this particular agenda. Further, the African Union has set up what we call the AU COVID-19 Commission, led by President Cyril Ramaphosa. And this oxygen agenda is key, is one of the key agenda or key items under consideration by the AU COVID-19 Commission, led by His Excellency President Cyril Ramaphosa. Colleagues, the adoption of this increased access to medical oxygen resolution at this year's World Health Assembly will undoubtedly take us a step closer to equitable and affordable access to medical oxygen. And this will save hundreds of thousands of lives in Africa. And as Africa CDC, we continue to support this resolution, and we continue to support the implementation, and we will not rest until each and every part of the continent of Africa becomes oxygen sufficient. So once again, on behalf of Africa CDC leadership, I really thank you, and I wish us all a successful deliberation. Over to you, Elvis.
Thank you very much, Dr. Tajuddin, for those very wise and supportive words. One take-home message here is Africa CDC, Africa Union is ready to support to ensure that everyone gets access to this key commodity. So we will move to the next part of our agenda, and I would like to invite Mr. Robert Matiru of Unit 8 to come and tell us why we need a global oxygen alliance. Over to you, Robert. Thank you.
Thank you very much, Elvis, and thank you to the Africa CDC and the Every Breath Counts Coalition for holding this really important webinar on the eve of the World Health Assembly that starts this Sunday, and during which we look forward to and hope that the seminal resolution on oxygen is adopted by member states. Thank you to all the speakers who spoke before me, setting a really important context on the criticality of sustaining our collective efforts to drive access to oxygen. It's hard to follow Taj with such energy and passion, but I'll do my best. As you can see, I'm the Director of Programs at UNITAID. I'm presenting today in my capacity as one of the co-chairs institutions of the new Global Oxygen Alliance, that's UNITAID, and my other co-chair is the Global Fund, and the vice chairs for this alliance are the Africa CDC and PAHO. So I'm just going to share with you a bit about the Global Oxygen Alliance, why we need it, and why it will be an important collaborative vehicle moving forward to continue the really important efforts of expanding equitable access to oxygen to everybody that needs it globally. If we go to the first slide, this is just the scene setting slide, and you heard from previous speakers just how much COVID-19, the pandemic that we're coming out of now, exposed how broken oxygen access was around the world, all around the world, but particularly in low and middle income countries and resource limited settings. We can all remember the really jarring images and stories on TV, on the radio, of thousands, if not hundreds of thousands of people running out of oxygen in health facilities at all levels. What was particularly jarring was seeing that this was a global phenomenon. It was happening in countries throughout Africa, it was happening in Asia, Latin America, it was even happening in high-income countries whose health systems we thought were more robust than what they turned out to be. So it took COVID to expose what was already a broken system. We knew how important oxygen was before this pandemic, for women, for children, for all the indications. So if there's any silver lining on this tragic pandemic, it's that it woke the world up to just how critical, among other things, access to this essential therapeutic and system is, and that the efforts that we all pursued to get this on the agenda and to support it must be sustained. We can't allow oxygen access to now fall out of the spotlight simply because COVID-19 has come out of the spotlight as we transition into the endemic phase of COVID moving forward. If we click to the next slide, which is the first of two, I'm just going to walk you through some of the important shifts. During the pandemic in 2021, at the height of morbidity and death that this pandemic was driving, particularly LMICs, the Oxygen Emergency Task Force was established under the therapeutics pillar of the Access to COVID Tools Accelerator. And that task force was set up in order to galvanize efforts globally, regionally, and nationally to support countries to quantify their needs during this pandemic, to link those needs into rational proposals for funding, to translate that funding into actual procurement of health equipment, be it PSAs, concentrators, commodities, infrastructure, as well as technical support at a very, very rapid pace. And that task force did a really important job in the last 2 years of not just driving important advocacy and demand generation for oxygen access, but actually translating needs into financing. We know that in the last 24 months, more than $1 billion was mobilized for oxygen access. It's a big number. It wasn't enough, but it was significant. 600 million of that through the Global Fund's C19 response mechanism, and another 400 million through agencies such as UNITAID, USAID, UNICEF, WHO, the Gates Foundation, ELMA, and others to really come together and support particularly LMICs to increase access to oxygen during the recurrent COVID waves, but also the other needs that were clearly being put under pressure during COVID for women in maternity wards, for children with pneumonia, malaria, and other fever drivers, and so on. So we've conceived collectively as partners through a very extensive consultation process, over 200 stakeholders, many of whom are in the room today on this webinar. How might a global oxygen alliance look as it transitions from the emergency task force? And the key pivot are along these dimensions. On the left, we want to move from a heavy emphasis during this pandemic on capital investments, so capital expenditure, to implementation of these investments and operations. So we have to translate that $1 billion, which is still in play, into actual delivered, installed, maintained equipment, but also infrastructure, as well as human capital, training, technical cooperation, and the like. I saw a comment in the chat earlier that it's not just about piped oxygen to the bedside. You need the nurses supported, you need the biomed engineers supported to maintain those cylinders or tanks outside. All that is required. We were very product specific during the pandemic. Countries requested PSAs, concentrators, consumers, ventilators, but this is a systems issue. It's about primary healthcare. It's about health security. It's about future pandemic preparedness and response. And so we must make it a systems issue that's cross-cutting across multiple purposes in national plans in countries. During COVID, it was ad hoc crisis, 24/7. Now we have an opportunity to take a step back, maintain a sense of urgency, but look at this in a more holistic, inclusive, and planned way. As you heard from Taj in the previous intervention, and also from Francine when she spoke about what Rwanda did, you need strong national response plans for an oxygen access roadmap built into a broader set of plans or roadmaps, as it may be the case, but we need a strong costed national roadmap, and this is a holistic one. Our focus has been COVID-19, but we know that there's 20+ health indications we need to focus on moving forward. And then because of COVID, oxygen access has been in the spotlight, and we can't afford that it comes out of that spotlight now. We can't go back to a place of complacency and neglect, where access to oxygen was actually a neglected issue. It was like a neglected disease, and we can't allow that to happen. We've come too far. We've lost too many lives because of that neglect, and it cannot happen again. So that's the shift from the task force to the Global Oxygen Alliance that is being aimed for by the partners driving this. If we go to the next slide. What are the near-term objectives and deliverables of GO? So GO was formally brought into existence last month. The Act A mechanism closed at the end of March. In April, the task force also closed and the alliance came into being. As I mentioned at the start, the alliance is co-chaired by UNITAID and the Global Fund, vice-chaired by PAHO and the Africa CDC, but also supported by WHO and UNICEF in the Secretariat. We made a very concerted effort to make sure that the membership of the task force in GO was expanded, in particular to have country voices. So we are including at the outset those countries that were LMIC countries as sponsors of the WHO resolution. And we also included civil society and additional donors, and then a very close alignment with the Lancet Commission on Oxygen Health Security, leveraging its collaborators as well to ensure we have an expansive set of stakeholders to support this work. The objectives are here. In the first top quadrant, you see the criticality of investment consolidation and sustainability. In simple terms, what does that mean? We mobilized $1 billion in the last 24 months. We must translate that into impact, sustainable systems and lives saved. So we shouldn't go immediately right now to ask for more money unless we can show impact with this money. But we do need to mobilize more resources because $1 billion is not enough. We know that for having these fully fledged systems in country. But we also need a better balance of those investments. Under the duress of proposals and applications to the Global Fund, to the development banks, to the other development partners, countries tried to get their asks correct and right, but there's an opportunity now to rebalance or reprogram. Maybe too many PSAs were ordered and you actually need fewer PSAs and you need liquid oxygen infrastructure or tanks. It's an opportunity to see if you can rebalance the needs based on a national refresh national plan and roadmap, and the opportunity for that is now in the coming months later. If you look at robust country maps and road planning, that will be key. We need strong, robust, costed national oxygen roadmaps. A number of countries have developed or are developing these. WHO, with support of partners in the Alliance, will convene an important workshop in late October exactly on this subject, national roadmaps for oxygen. We need coordinated technical assistance to continue, including to install and maintain a CapEx that's still being deployed right now based on the COVID funding that came through. And we do need to look at diversified financing options to sustain these systems in the future. Grant financing is important, but also so is development financing and public-private arrangements in countries also. Procurement, supply, and market shaping will continue to be key. We must ensure that access to oxygen remains affordable. The market has been highly concentrated. We want to grow this market, make it more competitive and resilient. To that end, in line with one of the key tenets of the Africa CDC new public health order, we want to support further local production of oxygen in Africa and other regions, starting with liquid oxygen and beyond. So that will be an important focus area as well. And then lastly, advocacy and demand generation, and partners such as the Every Breath Counts and others have done an incredible job ensuring that this issue remains visible and on the agendas of governments, development partners, and others. And GO will continue working with partners like EBC and others to ensure this continues to happen in multiple fora. The fora that look at resilient and sustainable systems, those that look at UHC, those that look at pandemic preparedness and response, because it cuts across all these major agendas moving forward. So in a week's time, or let me say in just over a week's time, on the 24th of May, during the World Health Assembly, the Global Oxygen Alliance will be ceremonially launched. And we hope that to mark the beginnings of what will be a meaningful, pragmatic, results-oriented coalition of partners to continue to drive this agenda. Thank you for the opportunity, Africa CDC, EBC, to share this with you.
Thank you very much, Robert.
That concludes the slides.
Thank you very much, Robert. I think for the interest of time, we would just give the floor now to Dr. Charles Olaro to tell us where the story started and why there was submission of this oxygen resolution. Dr. Olaro, you have the floor. Dr. Olaro, can you hear us?
Oh, hello.
Yes,
Can you hear me?
Yes.
Oh, thank you. Thank you. Can I be able to share my slides? Can I be able to share my slides?
I think Laith is working on that.
Yes, please go ahead, Dr. Olaro, and share your screen.
Okay. Thank you very much. Just a minute.
So if we have this logistic person, I think it would be too much for me. So this will be directly one of the.
So first of all, my apologies for joining in late, but I am looking at that. I also appreciate, because now when like I speak on the aspect of the resolution, on why the resolution for increasing access for medical oxygen, we've been able to listen from colleagues from some of the member states. So I will probably just be saying the obvious, but I must still think that I should be able to say it. So if you look at that, less than 50% of the health facilities in lower and middle income countries have uninterrupted access to medical oxygen. And in Uganda, 4.5 of the adults with hypoxemia in hospitals require oxygen. And only 1/3 of the health facilities have adequate oxygen supply to meet the demand. So 63% of them lacked adequate oxygen infrastructure. And as a country, we did government did undertake a number of actions. It implemented a national oxygen scale-up plan from 2018 to 2022, which guided the management of hypoxemia and setting up of the regional biomedical support workshops. And this also came with the installation of about 12 to 13 oxygen plants in the regional referral hospitals. In addition, also we developed the 5-year national oxygen strategy plan to guide the management and maintenance and distribution of oxygen. In all, we found that there was an increase of fourfold, an increase in government investment on oxygen. And we also went ahead and reviewed the clinical guidelines and expanded diagnosis and the use of oxygen for clinical care. So what this was able to achieve, that it was able to help in the treatment of hypoxemia, needed to achieve the goals and targets related to communicable, non-communicable diseases and conditions related to surgery. As all of you know that the WHO Global Action Plan for Prevention and Control of NCDs 2013 to 2030, the WHO NTB strategy highlights the aspect of oxygen. The WHO package of essential non-communicable disease intervention for primary health care, and also the WHO guidelines for safe surgery. All of them highlight the significance of oxygen. In addition, we also looked at it was critical for achievement of goals related to treatment of maternal, newborn, and child health, either the Global Strategy for Women, Children, and Adolescents Health 2016-2030, Every Newborn Action Plan, and the Integrated Global Plan for Prevention and the Control of Pneumonia and Diarrhea, and accelerating the progress towards achievement of universal health coverage. So, coming forward definitely from the members from the African region to co-sponsor the resolution in the upcoming World Health Assembly is a very commendable, and we really would want to thank the member states. So the member states from the African region who co-sponsored the resolution during the executive board meeting of the World Assembly in February, and also we want to applaud those ones who are coming to join now. We also want to applaud the global team of researchers from the Lancet Commission who supported Uganda to develop the draft resolution, and special thanks go to our colleagues from Makerere University School of Public Health. We also want to appreciate the Health Development Partners support initiative to increase access to oxygen, not just nationally, but globally. So I really want to thank you for coming forward, and I'm looking at that the oxygen ecosystem definitely, if improved, will have far much more reaching benefits and better outcomes for all of us. Back to you, Chair.
Thank you very much, Dr. Olaru, for sharing with us key areas where the oxygen resolution is going to affect other global initiatives. So as part of our program, we would also like to give the floor to Dr. Amadou Sidibe to share with us some success stories on the vital role of pulse oximetry as a gateway to rational use of oxygen, of medical oxygen. So over to you, Dr. Amadou Sidibe. Dr. Sidibe, can you unmute yourself, please?
Bonjour à tous. Merci pour cette opportunité que vous nous offrez de partager avec vous les expériences du Mali et de parler de cette question si importante qui est la question. Je suis le responsable de la PCIME au niveau du ministère de la Santé, la prise en charge intégrée des maladies de l'enfant. Et nous avons commencé vous pouvez partager les diapos. La première diapo, s'il vous plaît. Oui, je vais partager mon écran à mon niveau ici. OK. Donc, avant de commencer de répondre à cette question, nous allons tout d'abord rappeler un peu l'ampleur de la problématique au Mali. Juste pour rappeler les taux de mortalité néonatale au Mali. Les taux de mortalité néonatale au Mali, la dernière enquête qui date de 2018, qui est de 33 pour 1000 naissances vivantes, et le taux de mortalité infantile qui est de 54 pour 1000 naissances, le taux de mortalité infanto-juvénile est de 101 pour 1000 naissances. Partant de tout cela, et avec l'avènement de la COVID, COVID-19 en 2020, nous avons un projet qui avait commencé au Mali en 2019, qui s'intitulait le projet Améliorer l'identification de la détresse respiratoire chez les enfants. Et le projet a été lancé officiellement en pleine COVID, même si les objectifs ont même été revus, les activités à cause de la COVID. Le projet a été lancé en 2020 au Mali. Et parlant de ce projet, c'est un projet qui a concerné 2 districts sanitaires, autrement dit 2 hôpitaux de district, avec 44 centres de santé primaires. Et le projet était financé et exécuté par deux ONG, 2 partenaires, à savoir Alima et TDH, dans 2 zones différentes. Avant le projet, nous avons procédé à une évaluation primaire. Cette évaluation primaire a donné des résultats et parmi ces résultats, nous avons retenu 2. Nous avons voulu partager avec vous 2 résultats, à savoir l'utilisation de l'OP au niveau des structures des centres de santé primaires qui était seulement à 2% sur les 44 structures, et aussi l'utilisation de l'oxymètre de concentrateur d'oxygène aussi était de 2%. Et nous avions seulement aussi 66% de ces structures qui étaient tenues par des infirmiers et non pas des médecins. Comme objectif du projet, vous avez dit un objectif qui était de réduire, d'améliorer l'identification de la détresse, l'objectif principal chez les enfants. Mais à cela, il y avait d'autres objectifs, c'était surtout de produire des preuves scientifiques pour susciter un engagement politique auprès des décideurs au niveau des 4 pays du projet. Le projet était exécuté dans 4 pays de l'Afrique de l'Ouest, dont le Mali. Et le projet, avec la pandémie de la COVID-19 aussi, voulait donner des réponses par rapport à la prise en charge, la prévention et la lutte contre la COVID-19. Le projet était exécuté à 3 niveaux d'intervention. Il y avait 3 niveaux, au niveau de la communauté, au niveau des structures de santé et au niveau des hôpitaux de district. À chaque niveau, il y a eu des interventions clés. Au niveau de la communauté, c'était de renforcer la sensibilisation pour l'utilisation des services à temps. Et au niveau des structures de santé, c'était de renforcer la capacité des agents de santé et de les doter en équipement permettant de diagnostiquer à temps les cas d'hypoxémie chez les enfants qui sont associés le plus souvent aux cas graves dans la prise en charge intégrée des maladies de l'enfant, dans la PCME. Et aussi d'accompagner ces agents de santé et aussi d'accompagner les enfants malades, gravement malades. Aussi, au niveau des hôpitaux de district, c'était de renforcer le circuit d'oxygène, d'appuyer ces hôpitaux pour leur autonomisation par rapport à l'oxygène médical et dans la prise en charge des cas graves hypoxémiques qui seront référés des structures de santé. Et dans le cadre du projet, les résultats, quelques résultats, certains résultats ont été donnés. On peut revenir un peu sur la première diapo, juste la première diapo pour les résultats, quelques résultats qu'on voulait juste partager avec vous. OK, la première diapo.
Lead the first slide.
Okay. Donc, par rapport oui. OK, par rapport aux résultats, d'abord, dans le cadre du projet, il y a eu des formations, des dotations et comme résultat principal, nous avons, par rapport à l'utilisation de l'oxymètre d'époux dans la consultation, nous avons obtenu jusqu'à 80% des taux d'utilisation, c'est-à-dire des taux d'acceptabilité, d'acceptation de l'utilisation au niveau des agents de santé. Ce taux était allé jusqu'à 96% dans les sites de recherche. Et l'ensemble site de recherche, site opérationnel avait donné ce chiffre. Et comme valeur ajoutée de l'OPE par rapport au cas grave, on était jusqu'à plus 6,2%. Et l'OP a permis de rehausser aussi le pourcentage de décision de transfert des cas d'hypoxémie jusqu'à 61,8%. Et nous avons constaté que l'hypoxémie sévère était un facteur qui aggravait le taux de mortalité chez les enfants avec des cas graves. Et cela, on l'a constaté jusqu'à 35,5%. Alors que sans hypoxémie sévère, le taux, la létalité était juste de 2,2%. Diapo suivant. Slide. Et comme défi, le projet a permis de relever certains défis. Le premier défi, c'était l'accès à l'oxygène. Nous avons constaté qu'un gros défi, c'était l'accès à l'oxygène pour les patients gravement hypoxémiés.
CDB, can you hear us? I think
we lost him.
Yes. Okay. So thank you, Dr. CDB, for sharing the experience of Mali. I'll just do a small resume of what he was presenting. There was a situational analysis in Mali in 44 health structures, and only 2% of these used pulse oximeter. 2/3 of the use among nurses. So there was a roadmap to put an intervention in place, which involved community engagement, capacity building of healthcare personnel to diagnose hypoxemia within the integrated management of childhood diseases, and then to reinforce access to oxygen for the management of severe hypoxemia. Dr. Sidibé, vous êtes de retour?
Oui, c'était juste une petite coupure qui avait bloqué qui nous avait entravé. Donc, on peut continuer juste avec la suite des défis. Il y avait aussi le coût élevé de l'ordonnance pour les cas graves et le système de référencement du village au CSP. Et comme perspective et aussi les décisions, les mesures prises. Nous sommes en train d'élaborer un plan national d'oxygène qui tient en compte l'ensemble des préoccupations, à savoir la dotation, la mobilisation, l'équipement, le diagnostic, la prise en charge et la formation. Et aussi l'introduction dans les politiques, normes et standards des équipements du niveau périphérique, l'oxymètre de pouls. Ce processus est déjà un protocole national PCB en introduisant l'oxymètre de pouls. Aussi, tout récemment, à Madrid, le gouvernement du Mali a pris un engagement fort. Parmi ces engagements, les engagements du Mali, il y a la dotation de 50% des structures de santé privées primaires en oxymètre de pouls. C'est là pour faciliter le diagnostic et l'utilisation rationnelle de l'oxygène. Pour nous, nous avons constaté que l'oxymètre de pouls permettait certes l'utilisation rationnelle de l'oxygène, mais avant l'utilisation rationnelle de l'oxygène, ça permet d'avoir de diagnostiquer à temps les cas d'hypoxémie sévère associés au cas grave et aussi de rehausser le taux de référencement des cas graves. Et sans l'utilisation de l'OP, ces cas graves allaient rester et ces cas graves, sinon ces cas graves allaient traîner et on allait perdre du temps. Et il y a aussi un engagement par rapport à la dotation des hôpitaux de district en oxygène médical, 50% hôpitaux de district. Pour rappel, nous sommes maintenant à plus de 1400 centres de santé primaire au Mali. Il y a aussi le renforcement des capacités des agents et la formation en PCME pré-service. Le PCME pré-service, c'est pour renforcer la stratégie PCME au niveau du PCME. En résumé, nous allons juste mettre l'accent sur l'importance de l'utilisation de l'oxymètre.
Thank you very much, Doctor.
Ces résultats ont été partagés à l'ensemble des acteurs impliqués et aussi au niveau du cabinet. Et c'est ce qui a même amené le ministère.
Okay, thank you very much, Dr. Sidibe. For the interest of time, I think we would say that one of the main lessons that we learned from the experience in Mali was that the use of pulse oximeter permitted timely diagnosis of hypoxemia, rational use of oxygen, and increased reference of cases, of severe cases for further management. So just to, without much ado, I think we're going to give the floor to Dr. Freddie Kitutu, who is going to give us a brief reason why the Commission is so important for Africa. Over to you, Dr. Kitutu.
Thank you very much. I hope you can see me.
Yes, we can see you. Please, you can carry on.
Do you hear me?
We can hear you very well.
Excellent. Next slide, please. My name is Fred Kitutu. I'm a senior lecturer at Makerere University, and I'm part of the executive committee for the Lancet Commission. Next slide, please. So as we know, Africa still faces this disproportionate inadequate access to medical oxygen services. I think the message has been mentioned by every speaker on this webinar today. Medical oxygen, as we know, again, WHO, Adrian mentioned earlier, is an essential life-saving medicine with no substitute, and yet the condition for which we need medical oxygen, hypoxemia, low levels of oxygen in blood is deadly, and the current data shows that it increases the odds of death from 5 to 10-fold. Though the total hypoxemia burden remains unknown, and is part of the reason why the Commission is doing this work to be able to come up with an estimate. We know that Africa bears the disproportionately higher burden and is least ready to prepare to provide the required medical oxygen services. Our systems, as mentioned earlier by Robert, are still quite inadequate, and provision of medical oxygen system requires not just focusing on the products, but also supporting the systems to ensure that once the product is available, all the other ingredients required in terms of capacity of health workers, in terms of the working environment, supports provision of reliable medical oxygen. Next slide, please. So because of that, the Lancet Commission, which is a collection of many stakeholders, as we'll see in the next slide, including researchers, actors in the private sector, in agencies, came together. And at the center of the work is this cascade for oxygen therapy. I mean, for effective coverage of services adapted from a paper by Marsh that looks at on the vertical axis, the proportion of the population that a particular service is reaching, and on the horizontal axis, the different cascade. So for medical oxygen therapy, the target population, which is the first bar on the left of your screen, referring to patients who are acutely unwell with hypoxemia and therefore need to either undergo screening and then eventual treatment, and that is the ideal in the world. Currently, the Commission is trying to quantify what that burden looks like. But then among those who are unwell, there are those who come to the health facilities. They make contact with the former health facility. And that proportion, again, is small. The difference between the target and those who come to the health facility are, again, because of lack of knowledge or being aware, but also because of barriers such as costs, such as social barriers. But what we want to ensure that all those who contact the health service reach a facility that is ready to provide oxygen. And again, there's a difference between those who actually reach the health facility and those who eventually either get screened by pulse oximetry and eventually go on to receive medical oxygen if they need it. So this cascade basically breaks down the different proportions of populations that the Commission would like to synthesize evidence to improve access to, all the way to those who get medical oxygen, and those who get it appropriately, and those who adhere and complete whatever the regimen is. So in a nutshell, this summarizes the crux of what the Commission is working towards. Next, please. And here we'll see the questions the Commission is trying to focus on. So we have, the Commission work is organized in 4 thematic areas. The first thematic area that is trying to quantify what the burden for hypoxemia is, and therefore what the need for medical oxygen is led by my colleague, Dr. Ahmed Esanur, based in Bangladesh at ICDDRB, the Center for Childhood Illnesses there. The second thematic group is trying to look at what the definitions and metrics for measuring access to medical oxygen are. And this is led by a colleague, Dr. Hamish Graham, based in Australia, University of Melbourne. Our group at Macquarie University is looking at what oxygen solutions are available to close the gap in access that is illustrated in the cascade on the screen, but also to understand why, despite the existence of these solutions, the gap remains so high. And then we have the 4th thematic group led by Prof. Sengova Freddy at Macquarie University and Dr. Karina King at Karolinska. They're looking at what the financing and political economy implications of scaling up, spreading, and sustaining the currently available oxygen solutions. Again, as we see, the Lancet Commission is trying to synthesize evidence, try to identify what works best where, but also it's trying to identify what evidence we are lacking to stimulate research to generate that kind of knowledge. Next slide, please. Just re-emphasize the thematic group again across the 4 areas I've mentioned. The questions that are being asked will take into account the different care levels from primary level all the way to tertiary, including some aspects of home care, the different age groups, so older people, children, neonates, again, based on epidemiology in disease and occurrence of hypoxemia, looking at the different indications and how they manifest, including surgery, anesthesia, and cases of obstetrics and gynecological conditions, and most importantly, looking at the health systems component, transforming the efforts to strengthen medical oxygen systems into a systems approach, from working in silos, from looking at different components in isolation to looking at system issues for sustainability. Next slide, please. Who is involved in the Lancet Global Health Commission? At the center of the commission are 20 commissioners representing different geographical agenda and expertise. Of those 20, I can name off the number from Africa, Uganda, Kenya, Ethiopia, Nigeria, Dr. Falade, who is on the call, South Africa. And then we have colleagues from South America, Europe, Asia, and those constitute the commission. They are supported by the executive committee, for which I'm privileged to be part as part of the secretariat. Every Breath Counts Coalition, led by Leitha, who is the convener of this meeting, together with the Africa CDC and other partners. And outside the commissioners, we have the advisory group, again, where many of you in the call participate. And beyond the advisory group is 40, again, members representing different expertise, agencies, and bringing on board several experiences, including opportunities for financing. Then we have the Oxygen Collaborators, which is over 100 individuals and institutions, all interested in ensuring that medical oxygen access is improved for everybody who may need medical oxygen. So this is who is involved. And I think the last slide is how we can all get involved in this effort. And the call here on this slide is for all colleagues on this call in your different countries. First, to share evidence, either in form of reports, experiences, lessons from your countries on the topics that are being addressed: the burden of hypoxemia, the issues of medical oxygen access, the barriers, and how some of those have been addressed in your countries, oxygen solutions, what works where and when, and how do we improve access through ensuring adoption of the best available solutions today. And then what does it mean in terms of financing and to identify priorities for future research? Again, some of you have questions that you're probably asking, and you'd like a consensus on the approach next. Another way to get involved is Work Package 4, which is looking at financing and political economy, has developed an oxygen policy scorecard, which is intended for countries to use to assess their progress on how their systems are performing in increasing medical oxygen access. The scorecard will be piloted, and hopefully, for those of you who will be at the World Health Assembly, there will be interactions and feedback to ensure that the scorecard is useful for measuring progress and can be part of the tools that are used to monitor implementation of World Health Assembly resolution once passed. And lastly, a call for you to be part of the broad coalition, again, under, for instance, the Global Oxygen Alliance that Mr. Matiru talked about earlier, in making sure this issue remains on the political agenda, but also informing and accelerating investment efforts that have impact in terms of saving more lives that would otherwise die because of hypoxemia, which we know is treatable, also preventable, and also to impact towards stronger oxygen systems and to reduce mobility and mortality globally. Next slide, please. I think that's my last slide, and thank you so much at the Africa CDC and partners for organizing this. And I also like to acknowledge my colleagues, the executive committee, Laith, and the others, the commissioners, and of course, the institutions supporting our secretariat to do this work, FHI 360 and UNITAID. Thank you. Over to you, Chair.
Thank you very much. So let me just give the floor very rapidly to Dr. Bernard Olayo for some brief closing remarks. Over to you, Dr. Olayo.
Thank you so much, everyone. This has been a very, very rich exercise, a good seminar that precedes a very important meeting that is coming up to really bring the oxygen agenda to the highest level. I wish to, first of all, thank everyone who spoke today and for sharing your insights. I also want to thank the conveners for this important webinar, for all the work that has gone into the preparation. I will not fail to really try and summarize some of the key points that I had. One is that a lot of investment has gone into the oxygen space, and we need to sustain that. I also wanted to just link that to our learning from Hewatele, which is an oxygen company that has been in this space now for 10 years, running PSA plants in Kenya, Uganda, and more recently in Somalia. I would just want to tie one point that we've observed is that buying the PSA plants is one problem, but maintaining them is even a bigger problem. And without maintenance, we cannot get the best value out of them. So governments, funders, and health systems need to put a lot more resources towards keeping these technologies working. Number two, I think, was a call for advocacy for the highest level conversations with government, with international players, so that this agenda does not drop with the fall of COVID, which has recently been declared over by WHO from a pandemic perspective. So we really need to keep the conversation around oxygen going so that it doesn't fall off the radar screen of key investors, ministries, and key decision makers. And that's something that we would want to highlight. The last point that I want to talk about is the need for different types of investment. This is aligned to the agenda that Africa Union is pushing about local manufacturing. We have an example to share where Hewatele will be raising investment capital from DFC, CDF, FinFund, and others around $20 million to build Kenya's second and probably East Africa's largest liquid oxygen plant. So in addition to grants, what we are seeing is that it's possible that we can also get private impact funding into this space. And I'll be very happy to continue conversations with partners here that are keen to learn about how we can leverage private impact funding into the oxygen space, in addition to the grants that we are receiving. With that, I just wish to really thank everyone for coming in today. Thank all our partners that have come into the continent to support the oxygen agenda. Unfortunately, from today's meeting, the gap is still huge. So we need to sustain the investment and put in more resources so that we can eventually bridge the oxygen gap. Thank you so much, and back to you, Leith and team.
Thank you very much, Dr. Olayo, for those closing remarks. Dear colleagues, dear partners, I think we've gone past the time, and we would like, first of all, to thank you very much for your participation, and just a few take-home message on how we can support the oxygen resolution. The first thing is to prepare your ministers and ministry leaderships to support the resolution at the discussions that will be held at the World Health Assembly. To add your government's voice to the conversation on social media at Invest in Oxygen and WHA 76, and ensure that your government delegation attends the special UNIAID Path WHO Oxygen Site event in Geneva on the 24th of May. So you can send an email to Elena to get more information on this. And on this note, I would like to thank everyone for their contribution to ensure that everybody who needs oxygen actually gets it. And in the right way and in the right quantity. Thank you very much, and thanks for staying beyond the predefined time. Have a nice evening, and we continue to engage. Bye-bye.
Thank you. Thank you.
Thank you, everyone. Bye.
Thank you all. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Everyone.
Everyone, see you next
Bye.
time.
Bye-bye.
Bye, everyone. Bye.